Okay, so picking up on the second part of where we left off in week 7, chapter 32. We are mixing two medications in a single syringe. When a physician orders two medications, it is sometimes possible to combine the two drugs into one syringe, thus making it possible to give one injection instead of two separate ones. It's important to check with the physician or pharmacist to see if the two medications can be combined. Some medications are incompatible and may cause problems when combined. I have to be honest with you, except for insulin, we don't do this a whole lot in clinical practice. When combining two medications, the medical assistant must determine which medication is the primary drug and which is the secondary drug. The primary drug is the first drug drawn up into the syringe, and obviously the secondary is the second. When it comes to insulin, the primary drug is the clear insulin, and the second is the cloudier insulin. So medication cartridge devices, they are sealed, pre-filled disposable glass cartridges that hold a single dose of medication. Some examples that come in medication dose cartridges are Phenergan, penicillin, Depo-Provera. They require no mixing, no special calculations, and are easily administered. The cartridge needle fits into the cartridge unit syringe, and usually you hold on to that cartridge unit syringe. That can be used multiple times, whereas the syringe, the disposable part, the disposable cartridge here, is obviously disposable. Pre-filled syringes. Many manufacturers are turning to disposable pre-filled syringes that contain unit doses of medications and may be glass or plastic. They're even easier to use than a cartridge set because they're ready to go. You literally just screw a needle onto the end of it, and then you've got a ready-to-use medication. So, when we're about to administer medications, we prepare only one medication at a time and for one patient at a time. If there are multiple injections to be given, prepare each one separately and label syringes or syringe wrappers with a marking pen so that you can identify which syringe holds what medication. You also want to follow safety precautions when dealing with needles and syringes and ensure that contamination does not occur to the equipment during preparation or transport. You also never want to allow another healthcare worker to prepare the medication you will administer unless you're working in an emergency situation and that's the only thing that can be done. You want to follow the 7 rights of medication administration we talked about in Chapter 30 and use 2 patient identifiers before administering any medications. We're going to check the patient's allergy status prior to administering any medication, and we're going to wash our hands and wear gloves just prior also to administering any medications. Never allow a patient to stand up while receiving an injection. They should be sitting or lying down. Sites should be free of scar tissue, wounds, lesions, rashes, moles, or any other disturbances of tissue growth. And you want to select a clean site, and you want to clean the site using a circular motion with an alcohol swab prior to injection. It might also be a good idea to stabilize your hand while holding the needle and syringe. And you want to follow the same track coming out of a site that you used for going in. Immediately once you take that needle out, you're going to engage the needle sheath or safety device on the syringe, and then you're going to dispose of that whole unit in a sharps container. Patients should really be monitored for 20 to 30 minutes following injection in case of anaphylaxis. So let's talk a little bit about angles of insertion. This is the angle that we want to use when administering medication, and it's based on the route of our injection. So the angle helps us keep us in the correct layer of tissue or muscle. So first of all, a 90-degree angle is always used for intramuscular. As you can see, that's the deepest part that we're going to, and we want to go straight down. Subcutaneous is usually a 45 degrees, so right in between 180 and 90. And that gets us into the subcutaneous layer of the skin. Intravenous is going to go at a 25-degree angle, and we'll find those blood vessels that you're looking for. And intradermal is the topmost layers of skin, and that's going to be a 10 to 15 degree angle. So aspiration is a common practice when administering medications. The term aspirate means to pull back slightly on the plunger to look for blood in the tip of the syringe to see if you are in a blood vessel. The thought behind aspiration is that depositing drugs that are meant for slower absorption directly into the bloodstream could result in complications to the patient. The latest studies, however, state that there is no reported evidence that aspiration with or without blood return confirms needle placement. As a matter of fact, the following organizations now state aspiration is not necessary when administering vaccines. CDC, the ACIP, which is the Committee on Immune Practices, Department of Health and Human Services, and American Academy of Family Physicians. So we do not do aspiration for intradermal injections or for subcutaneous injections. You'll want to check with provider regarding aspiration for allergy injections, and aspirate on IM injections except for immunizations. After you give an injection, you may want to massage the site. After subcutaneous and intramuscular injections, gently massage the site to help disbursement of medications. And you'll want to use a cotton ball or a gauze pad over the site of administration so that you're not having blood flowing out of the wound. Massaging is contraindicated when performing all intradermal injections due to disbursement of extract into deeper tissue, as well as all Z-Track injections. So we're going to monitor our patient when we're massaging the site after injection. We want to observe them for anaphylaxis. You don't have to massage for 20 to 30 minutes, but you do want to monitor your patient. You want to also observe her site for local reactions and ask if they're experiencing anything out of the ordinary. You're going to provide patient education about whatever you've just injected them with, and you're going to document the procedure and follow up observations in the patient chart. So, routes of administration. We've talked about this a little bit already. Intradermal is anything pertaining to the skin. Needle is positioned at 10 to 15 degrees, and a wheal should appear on the outer surface of the skin, and that's what you see here, a little raised area. The intradermal injections go right into the epidermis, the outer layer of skin there. Common types of injections administered through this route include testing for allergies, TB test, and that's about it. It's pretty uncommon, actually. Really, the most common thing you're going to see in healthcare is PPD testing. Common intradermal sites are on the forearm here, as well as on the back here. Subcutaneous injections. If this means just under the dermis or the true layer of skin. Subcutaneous tissue is made up of fatty and connective tissue. When administering subcutaneous injections, the adipose tissue should be slightly pinched between the finger and the thumb to help differentiate the adipose tissue from the muscle. The injection is placed into the fatty tissue of the body, not the muscle, and we use a 45-degree angle to accomplish this. If they have a lot of adipose tissue, you may need to use closer to a 90-degree angle. Aspiration is no longer recommended again for majority of medications given subcutaneously. And some common sites here include the outer portion of the upper arm, the belly, and the thigh here. Intramuscular injections are given within the muscle. They use a longer needle and a steeper angle of 90 degrees. The needle must be long enough to penetrate through the skin and subcutaneous tissues deep into the muscle. And you're going to hold the tissue over the muscle taut when you're administering this medication. Common sites here are ventrogluteal. This is used for patients of all ages. This site is free of major nerves, and we're talking right around this large muscle here, okay? Where they've got their hand sort of placed and they're pulling the skin taut. An X marks the spot, as you can see. Considered safer than dorsogluteal because there are some nerves back here, okay? So ventrogluteal. Also the vastus lateralis, which is the outside of the leg. As you can see, this person's skinny little thigh here probably doesn't have a whole lot of muscle, but you'll get in there. This can also be used for adults, but it's the preferred site of injection on infants and younger children. It's relatively free of large vessels and major nerves. The deltoid site, not recommended for infants and small children because they don't have a whole lot of fat there. It's used for thinner, less viscous medications, and no more than 1 ml of medication should be given here. So a Z-Track method. This is used when the medication may cause irritation to the skin and cause discoloration of the tissues. This method seals the medication deeply within the muscle and allows no exit back into the subcutaneous tissue and skin. Usually, the skin or subcutaneous tissue of the ventrogluteal tissue are displaced and pulled laterally before the needle is inserted by placing the palm of the non-dominant hand on the surface of the skin and pulling it several inches to the side. This hand should not move until the end of the procedure. The needle is inserted and the syringe is aspirated, one-handed technique, to make certain the needle is not in a blood vessel. So you're going to inject the medication and then wait 10 seconds before removing the needle and holding the tissue to help create a seal. The displaced tissue, once you let go, will return to its original shape or location and stop the medication from leaking out into the subcutaneous tissue. Common medications given by Z-Track include iron preparations and medications that are irritating, such as Vistarel. Parenteral complications. Complications can come in many forms, but most commonly it's usually because you didn't change a needle in between the vial and the patient, or maybe you used a needle that was too short or too long, failed to aspirate where indicated, or there was a break in sterile technique, and this opens up the patient to infection. Maybe you chose an underdeveloped muscle, or perhaps you used a small gauge needle when administering a viscous solution. So we're going to take a look at Table 32.8. Just to take a look at some possible parenteral complications. Make sure you avoid those when you're practicing on your patients. So, you want to help patients stay up to date with immunizations. That's one of the things that you can do as a healthcare professional. Immunizations happen all throughout life, all the way up and through the elderly. We want to provide patient education about the newest vaccines available and any changes to the guidelines. And Figure 3230 is a common immunization schedule, and that includes adults all the way up past 65 years of age. So let's go over the basics of IV therapy. Intravenous means administration of fluids or medications directly into the vein, and a lot of medications are administered this way, usually through an IV site. IV injections versus infusions. Injections, also commonly referred to as boluses, are a small amount of fluid introduced into the veins. Infusions are larger amount of fluids introduced into the vein and go in over a longer period of time. The purpose of administering IV fluids is to replace lost fluids, give medication, solutions, or nutrients, and laws vary from state to state as far as whether medical assistants can perform procedures directly related to intravenous therapy. So equipment and supplies. Equipment and supplies are continually being updated to comply with federal and state laws regarding safe work practices for patient comfort. Containers for IV fluids have changed from glass to pliable plastic bags these days that are lightweight and not at risk becoming broken or damaged. IV fluids range from 50 to 2,000 mLs or more, and smaller bags are called piggybacks, whereas larger bags are called large volume parenteral solutions. Common solutions include 5% dextrose, normal saline, dextrose in saline solutions, and Ringer solution. And a lot of times medications will be diluted into these solutions for infusions. So when we talk about an IV line, this is how fluids get from the bag to the patient through here. The top is the piercing pin that goes into the plastic bag. This is the drip chamber. This is the flow control right here. You can open it up or close it down. This is the tubing. Here's an injection port where you can inject a bolus medication in, as well as a slide clamp if you need to clamp off right before the line. This usually locks onto a lower lock device that connects to an IV site. So, we kind of just went through all that. We talked about the roller clamp. Up is open, down is closed. You have a little eye here, and the larger part is open, and if you slide it over, it's closed. Let's see. So infusion of fluids can either be through gravity flow, controlled by the roller clamp on the IV tubing, whether it's wide open or slightly shut down, or on an infusion pump, which is a more precise way to get the patient exactly what they need as far as drips per minute, or mils per minute, or mils per hour. It usually sounds an alarm as well as if there's an occlusion or a blockage detected, and it will tell you when the infusion is done. Documentation of IV therapy. Healthcare professional that inserts and starts the IV is responsible for documenting the procedure. You want to put in the patient's chart the IV site location, the number of attempts at insertion, any complications or adverse reactions to the procedure, the date and time it all happened, as well as the needle gauge and length that you've got in their arm, or wherever the site is, and the initials of the person who inserted the catheter. Let's see, just want to see how much more we have to go here, because I think we're going to run into a third lecture. So one more slide. Yep, let's start that third lecture. We'll go ahead and get this one done. So look for that third lecture. This is a long chapter, but I want to make sure we get through all of it. And I'll see you guys part 3.